This lecture, we're going to talk about the drugs used in the therapy of shock. So, what is shock? Shock um, is a condition of acute circulatory failure. So, what's the function of circulation? The function of circulation is to reach oxygen, nutrients, and to remove the waste products of metabolism. Remove the waste products of metabolism. So, if there is acute circulatory failure, it means that the cardiac output is inadequate to um, to provide adequate tissue perfusion. Um, so the important word being that there is inadequate cardiac output, okay? And because of that, the tissue is not adequately perfused. Because it's not adequately perfused, there is inadequate amounts of oxygen reaching the tissue, um, inadequate amounts of nutrients, and the waste products of metabolism are not removed efficiently. So, if this is not mitigated, if this is not treated, then it can be life threatening to the organism. And so that's the importance of the drugs used in the therapy of shock. Okay. So how can we clinically define shock? So we could say that the systolic blood pressure, the systolic blood pressure, when it is less than 90 millimeters of mercury, okay? Or the mean arterial pressure is less than 70, okay? And that is associated with, if it's associated with tachycardia, um, or any organ function, organ perfusion abnormality, then we can say that the patient might be having shock. Okay, so the patient might be in shock. Okay. So, how do we classify shock? So, we classify, for the purpose of this lecture, we would be classifying shock based on the etiology. Okay. So, according to the etiology, shock could be classified as hypovolemic, it could be cardiogenic, it could be obstructive, or it could be vasodilatory, or distributive. So hypovolemic. Hypovolemic would be a shock that is associated with either blood loss or fluid loss. Okay. So what could be the examples of blood loss? Yes, hemorrhage. This could be secondary to a bleeding ulcer. or it could be, say, excessive uh, removal of blood from the female body, like menorrhagia. Um, or it could be um, due to trauma. Okay, due to trauma. So there could be blood loss due to all these common factors. Or it could be maybe from an ectopic pregnancy. Okay? Menorrhagia being, you know, vaginal bleeding. Okay, so this could be the most common causes of blood loss. Fluid loss, it could be due to um, dehydration. It could be if the person is having uncontrolled diabetes mellitus. Those kind of conditions can cause fluid loss. Okay? So if you have full fluid loss, so we know um, blood pressure equals the cardiac output into total peripheral resistance. So cardiac output is end diastolic volume into heart rate times total peripheral resistance. Okay? So um, if the end diastolic volume is reduced, which happens in these conditions, then definitely the blood pressure would decrease, and um, it is evident that the cardiac output would reduce as well. Okay, and that could lead to hypovolemic shock. So cardiogenic. So by cardiogenic, we mean if there is a problem with the heart, say myocardial infarction. Okay? So in this condition, the heart wouldn't be able to pump and maintain perfusion. That can lead to shock. Obstructive. Obstructive could be due to, say, pulmonary embolism. Okay. Or a clot anywhere in the circulatory pathway can result in obstructive shock. Vasodilatory shock or distributive shock is usually what we see in anaphylaxis. Okay. Or due to endotoxins, there could be massive distributive shock. Okay. So as we alluded to earlier, the most important and most common one is the hypovolemic shock. So as far as this chapter is concerned, we would be more concerned about the drugs which are used to treat hypovolemic shock. Okay. So how do we treat? So treatment. Okay. So if this is the etiology, we have classified based on the etiology. So the treatment directed at the etiological factors, that's called primary treatment. Okay? For instance, if you've got hemorrhage from exposed blood vessels, then you do a surgical intervention. You tie off the blood vessel and you prevent the further loss of blood. Okay? Or if you're having a septic shock, which is a distributive shock, the cause is the microorganism which has caused sepsis. So you treat the causative organism for the shock by giving antibiotics and corticosteroids. So those kind of interventions which are targeted at the etiological factors of shock come under primary treatment. Okay? Secondary treatment is the drugs that we are going to study henceforth. Okay? So the drugs that we say are the drugs for shock are basically the drugs which are used in the secondary treatment of shock. So as alluded to earlier, hypovolemic shock is the most common kind of shock. Okay? So the reason is that the volume of either the blood or the fluid decreases, and that results in shock. So how would we try to overcome this problem? Okay, so if the problem is the loss of fluid, then what we could do is replace the fluid, right? So that is the first secondary treatment for hypovolemic shock. Okay? So you could either replace the blood that's lost or the fluid that's lost. Um, those are basically IV fluids, right? So if you replace blood, that's an IV fluid, and then there are non-blood fluids that can be given um, in conditions where there is no blood loss. Okay, so bear in mind that this blood loss can also be due to surgery. Okay? So surgical blood loss, we try to replace the blood that is lost. Okay, all right. So which brings us to what could be the drugs for drugs used in the secondary treatment of shock. So the drugs that are used for shock, the drugs for shock, we can classify them as the first class that we are going to look at is IV fluids. Okay? And when the IV fluids don't work, then we have got two classes of drugs which are basically um, vasopressor agents and cardiotonic drugs. Okay? Okay? Or inotropic drugs. Okay? So these are the most important classes of drugs for shock, which we would be looking um, as the lecture progresses. Okay? So the first class of drugs that we're going to look at are IV fluids. So IV fluids, we said that shock could be due to the loss of blood or fluids, right? So if it's blood loss, we give blood, and if um, if blood is not indicated, then we use the non-sanguineous IV fluids. Okay, so IV fluids can be classified as sanguineous and non-sanguineous. Sanguineous meaning blood or blood products. Okay, so a better terminology would be blood products. Blood and blood products. Non-sanguineous could be non-blood. Okay, so these are non-blood or non-sanguineous drugs. So the blood and blood products, so if we can have whole blood, and whole blood can be fresh or stored blood. We can have packed RBCs, we can have platelet-rich concentrate, we can have cryoprecipitates, and we can have um, clotting factor concentrates. Okay? All right. The non-sanguineous one, we classify them as crystalloids and colloids. So the operating definition for crystalloids would be any product that's less than 30,000 daltons. Okay? So that's 30 kilodaltons. Okay? So, yeah. So crystalloids are basically salt solutions. So what are crystalloids? They are solutions of electrolytes. Okay, what are electrolytes? Electrolytes are soluble salts that ionize. Okay, so um, the non-sanguineous IV fluid sample is crystalloids. Okay, so what are crystalloids? Solutions of electrolytes. Electrolytes are soluble salts which ionize in water. Okay, ionize in water. Okay, so these crystalloids again are classified as balanced and unbalanced. So what is balanced? So what we mean by balanced is if the ion composition is similar to plasma. Okay, if the ion composition of a solution of a crystalloid solution is similar to that of plasma, we call it balanced. So which is not similar to plasma, we call it unbalanced. So what's the example of unbalanced crystalloid solutions? It's normal saline and normal saline with dextrose. What is NS? Normal saline. Okay, 0.9% NaCl, sodium chloride in water. Okay, water for injection. Okay, so that is normal saline. Normal saline with dextrose, again it is unbalanced. So why do we call it unbalanced? Because normal saline contains greater concentration of chloride compared to plasma, and therefore it can cause alkalosis, as well as hyperchloremia. Okay. It can cause hyperchloremia and alkalosis. Now, alkalosis is all the fluids can cause alkalosis. Okay. So it interferes with the acid-base balance. So most of the fluids, most of the crystalloids can cause alkalosis. So how is that mitigated? How is that overcome? It is overcome in the formulation. What is formulation? The method of preparing the pharmaceutical preparation. Okay. So by formulating it along with, say, um, anions. Okay, so chloride is a cation, right? So if you formulate it well along with anions like acetates or lactates, okay, so you formulate the solutions with anions like acetates or lactates. What happens is these things get metabolized in the body to bicarbonates. Okay, so um, they can prevent alkalosis. Okay, so most of these formulations are formulated as acetates or lactates because eventually these salts get metabolized to as bicarbonates, and these bicarbonates can prevent alkalosis. Okay, right. So yeah, so to remember, among the different formulations, acetates and lactates, um, in shock, the body finds it difficult. The body, it is difficult to metabolize lactates. Okay, so acetate salts are a better acetate containing crystalloids are a better bet in the treatment of shock. Okay, so that's about unbalanced crystalloids. So balanced, we've got Ringer lactate, we've Hartmann solution, we've got Plasma Light 148, we've got acetylated Ringer, and we have explained why we have acetylated Ringer. Then there are a couple more balanced solutions which are used in the clinic. Now, a word about Plasma Light. Plasma Light is a multi-electrolyte. Okay, multi-electrolyte. Okay, so So what is multi-electrolyte? So it contains sodium chloride, sodium gluconate, sodium acetate, uh, trihydrate, and it contains potassium salts, potassium chloride and magnesium chloride. Okay. So plasma light here, it is a multi-electrolyte. It's giving lots of different kinds of salts: potassium, magnesium, sodium. Right. Okay. So and then it's balanced as well. Okay. So it's one of the uh, newer preparations. It's a multi-electrolyte. Okay. So these colloid solutions, crystalloid solutions, they've got a small problem. Okay, they are not very osmotically active. Okay, so they're not very osmotically active. They're not um osmotically active compared to colloids. Okay, so it's relative, right? Relative to colloids, they are not very osmotically active, which means if we inject a crystalloid solution into intravenously, suppose, um, it's not going to remain uh, in the uh, blood vessels in any sufficient quantity. Okay, as much you inject. For example, if you inject 1 liter of sodium chloride, which is 0.9% normal saline. Okay, so if we mean normal saline, if we inject 1 liter, then around 200 ml remains intravascular. Okay, so what happens to the rest? The rest goes into the tissues. So because it goes into the tissues, if you overload a patient with this preparation, what's going to happen? The fluid is going to accumulate in the periphery. Okay? So the patient may have either edema or pulmonary edema. Okay? So the crystalloid solutions have got these adverse effects. Okay? They can cause alkalosis, they can cause hyperchloremia, okay, and they can accumulate in the tissues, and they can cause edema and uh, pulmonary edema. Okay, so this is what we encounter when we give overload the patient with crystalloid solutions. Okay, all right. So because of this, the colloids have been formulated. So what are these colloids again? So working definition would be they would be high molecular weight polymers, high molecular weight polymers. So it should be greater than 30 kilodalton, right? Okay, so it's more greater than 30. Average is about 60 kilodaltons. Okay, so that's the average molecular weight of colloids. Now, colloids, they are classified as natural and semi-synthetic. So the natural colloids are plasma, okay, and albumin. Okay, albumin is the most abundantly available protein in the blood. Okay, it's an abundant protein which is present in the blood. Plasma, we know, okay, it's the fluid part of the blood. It contains plasma proteins, and those plasma proteins are responsible for the osmotic effect. So we said that colloids are osmotically active. Okay, they are highly osmotically active, which means if they are injected into intravenously, they tend to remain in the vasculature. Okay, so you inject osmotically active compound into the blood vessel. So this is a blood vessel. So if you inject it, what's going to happen? It's going to pull in the water from the surrounding. Okay, so it'll pull the water into it because this molecule here, the polymer, is osmotically active. So as a result, for example, if we give, say, dextran, say, about 100 ml, so we would get approximately 130 ml in the vasculature. Okay, so that's something that we need to um, remember about osmotically active compounds. Okay, so um, yeah, so usually if you give about, let's not specifically talk about dextran, we give solutions which are osmotically active, then the chances are that for every 100 ml we get approximately 130 ml of fluid remaining within the blood vessel. Okay, so which means that um, for every if you give say 100 ml of um, the colloidal solution, you need to give at least 300 ml of um, crystalloid. Okay, so that's 1:3. Okay, if we compare the uh, equal fluid retaining capacity, if we give say 100 ml of colloids, that is equivalent to 3 times its volume of crystalloids. Okay, so definitely giving colloids is an advantage, right? Considering from this point of view, for a very small administered volume, you get a considerable increase in the vascular volume, and that can increase the cardiac output. Okay. So yeah, so they're classified as natural and semi-synthetic. In the semi-synthetic, they've got dextrans. Okay, and this dextrans, commercially we see dextran 6% dextrans 70, 3% dextrans 60, which is the most commonly used dextrans. So what is this 70? 70 implies the average molecular weight, which is 70 kilodaltons. Okay, and 60 would be 60 kilodaltons, and 40 referring to 40 kilodaltons. Okay, so it fits into the definition. We talked about colloids having a molecular weight of greater than 30 kilodaltons. Okay. Then we have gelatins. Okay, gelatins, the commercially available forms I've listed here. And then there is hydroxyethyl starch. Okay, and that the commercially available one is listed here as well. Okay, so 200 meaning it's 200 kilodaltons, 0.5 means 50% solution. Okay, so this is 200 kilodaltons, and this is 50%. Okay, so that's the commercially available starch, which is used clinically as a IV fluid. Okay, so now let's define the drugs that we have talked about. Okay, the colloids. So what is dextran? So let's write it here. Dextrans. Okay, they are glucose polymers. Okay, so the starting point is glucose. You introduce a microorganism which is leuconostoc, mesenteroides. Okay, Leuconostoc mesenteroides, and this bacteria converts it into dextran. Okay, so there is it's a glucose polymer, um, and then using this bacteria, we convert it into dextran. So dextran is purified from the metabolic product of leuconostoc, which has gorged upon the glucose, right? So it's purified basically from the metabolic product of leuconostoc mesenteroid fermentation, which means this dextran could be contaminated with the other proteins um, which can be either the byproducts of leuconostoc, or it could be the breakdown products of leuconostoc itself. So foreign proteins would be present in dextran. So if foreign proteins are present, what could be the adverse effect? Yes, anaphylaxis. Okay, so that is one of the um, adverse effects of dextran. Okay. Um, so, what's happening here? We are adding dextran to the blood vessel. We are introducing dextran. What's going to happen? The fluid in the vasculature is going to increase, right? So if the fluid in the vasculature increases, what could happen? It could dilute. It could dilute the blood. Now, if it dilutes the blood, it means that it could dilute the clotting factors, right? Clotting factors would get diluted. As a result, there is a risk of bleeding. Okay, so the two important adverse effects of colloids are it can cause anaphylaxis and it can cause bleeding due to the dilution of the blood. Okay, so those are the most important adverse effects. Okay, and this adverse effects is common to almost all the semi-synthetic colloidal preparations. Okay, so what is gelatins? Okay. So we've talked about dextran. Let's now talk about gelatins. Okay. So what are gelatins? So they are basically hydrolysis products of hydrolyzed products of polypeptides, which are derived from bovine collagen. Oh, sorry for that. Okay, so they are hydrolyzed polypeptides which are derived from bovine collagen. So polypeptides, again, they are proteinaceous in nature, and they can also cause anaphylaxis. Okay? And again, this thing also dilutes the blood. Again, it can cause bleeding. Okay? So the molecular weight here is about 30 to 35 kilodaltons. Okay. Dextran, on the other hand, was how much? It is about 40, 60, and 70. Okay, so this is less. Okay, so fluid retention. So let's say fluid retention in the vasculature is related to the molecular weight. Okay, so higher molecular weight compounds would be retaining much more fluid intravascularly than the smaller molecular weight molecules. Okay. Okay. Let's what's left? What's left is hydroxyethyl starch. Okay, so what is hydroxy ethyl starch? They are um, polydispersed solutions of ethoxylated amylopectins. Okay, right. So because it's chemically pectins, it's got less allergic potential. Okay, so this hydroxyethyl starch, did I mention here? Okay, so they are available as 3%, 6%, and 10%. Okay, and they have got the um, strongest effect of increasing the. They've got the strongest effect of increasing the intravascular volume. Okay, why is that? Because they've got the highest molecular weight. Right? Okay, they've got 200 kilodaltons is the average molecular weight of this particular preparation. And because of that, they've got the strongest effect on the intravascular volume. Okay. Um, yeah. So hydroxyethyl starch, let's say 10%, if you give 100 ml of 10 percent solution, then we would get about 130 ml of increase in volume. Okay, as we explained earlier. Okay. So an example for that better than the dextran would be an example of hydroxyethyl starch. Okay, and the half-life of this preparation, hydroxyethyl starch, the T half is about 48 days. Okay, so naturally, what could be the for dextrans? It is approximately 24 hours. Okay. So commonly we use dextrans and hydroxyethyl starch. So now we know the half-life of these drugs. Okay. There is one more point I wanted to tell. Albumin. Okay, about albumin. Albumin has got some advantages as well. One is that it inhibits platelet aggregation. Okay. Secondly, it acts as a free radical, strike that off, free radical scavenging. Okay, so free radical scavenging effect is seen with albumin. So that's an added advantage of albumin as a replacement fluid. Okay, but to remember, how is this plasma produced? Okay, so blood is taken from volunteers, and then it is pooled, okay, then centrifuged to remove the plasma. Okay? So as it comes from pooled blood, it could be contaminated with foreign proteins, okay, and that can cause anaphylaxis. And then all these blood products have got this another problem as well, that they carry risk of viral infection and transmission of other diseases via blood, and then there is chances for contamination in the storage or the dispensing to the patient and the administration to the patient. Okay? So only when it is indicated is sanguineous fluids transfuse to patients. Um, and yeah, and so if we look at this, there are lots of blood components, right? So the question is, why can't we give blood? Why do we have different components? Why do we separate the blood into different components? The reason being, the components have got a high lifespan, okay, or shelf life. Okay, shelf life is greater for the components compared to blood. Okay, blood about it's got a shelf life of about 7 days. Okay, so that is why um, the um, that's why this we have got this pharmaceutical preparations which are basically components of blood. Okay, so when we transfuse, logically we need to put these things together again, right? So usually it's given in a ratio of 1 is to 1 is to 1 or 1 is to 1 is to 2. Okay, so what is that? Plasma is to platelets is to packed red cells. Okay, and obviously when you make it into this, you also need fluid water, and this hydroxyethyl starch is compatible with blood. Hydroxyethyl starch is compatible with blood and blood components. Okay, so it can be used as a diluent as well. Okay, right. So this, when you give it like this is called a balanced transfusion. Okay, when these components are administered in this ratio, we call it a balanced transfusion. Okay, all right. So in this lecture, we have, in this part of the lecture, we have covered the drugs for shock, which is the IV fluids. Okay, so in the next lecture, we're going to talk more about the drugs which are listed here, the vasopressor agents and the inotropic drugs. Okay.